Welcome to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together over 80 national associations of Christian doctors and dentists from all over the world. And it's the D of ICMDA dentists that's very much in priority today. And we're privileged to have Dr. Roshan Kharel speaking on dentistry in remote settings during COVID. And Dr. Kharel is the head of the dental department and deputy medical superintendent at United Mission Hospital, Tanzan in Nepal. But he went to dental school in Ukraine, and the Lord chose him when he was in his second year of dental school to become a Jesus follower. And spiritually, he grew up reading a Russian Bible. So there you are. God is active in every country. And Roshan joined the mission hospital in Tanzan, which is in the western part of Nepal, in the year 2000, where he got married to Esther. His wife Esther, who's professionally a nurse, teaches in a nursing school, and they're blessed with an 18-year-old son and a 10-year-old daughter. So Dr. Kharel, it's a great pleasure to have you today on ICMDA webinars, and I'll hand over to you to speak to us on dentistry in remote settings during COVID. Thank you.
Thank you so much, Dr. Peter. It's wonderful to be able to share with you all, and I'm so blessed to be able to share with all the team here, all my dear friends and colleagues who have joined in to talk about how in Tanzan we are managing the department during this COVID. Yeah, and so, it's been, I'm sure many people around the world are going through a terrible time during this pandemic. And the Lord has been gracious to all of us here in Tanzan. By God's grace, we all are managing well. And, there has been ups and downs, changes, that has come, and the culture has changed, of course, not only Nepal and many parts of the country, many parts of the world. Yeah, so I just want to show briefly on how we are managing it. And so first of all, I would like to welcome you to Tanzan, Nepal. Tanzan is located in the western part of Nepal. And I work in the hospital, in the mission hospital called United Mission to Nepal, which is, again, in the western part of Nepal. Now, Nepal is located between between India, North India, and China. And Tanzan, it's about 400 kilometers east to, west to Kathmandu. Kathmandu is a capital city. Now, looking upon the map, the roads to Tanzan is not as straight as it is shown in this map. So it takes about 10 hours if all the roads are good. It takes about 10 hours to reach to Tanzan, to Mission Hospital. Now, I would not say right now Tanzan is as remote as it used to be 20 years ago, but the road access is very difficult. And compared to Kathmandu, of course, we are remote. So today I'm going to talk, give you some glimpse of our activities before COVID, so that you all would know how, we are suffering because of COVID. All our activities have been suffered because of COVID. And also I would like to talk to you about how we have acclimatized with the lockdown, and how the lockdown was introduced to us, and also how we have prepared. When I say we, that is not only the staff of dental department, but staff of the hospital. And then how we have been prepared and trained, and also then I will talk to you how we are dealing it currently. Now, we used to have a regular clinical activities without hat and without PPE, and many faces around, and we used to take things not as seriously as we do it now. And we used to have, outreach in different areas, like in prison. uh, we were also involved. My team was involved in giving oral hygiene classes and trained people how to brush their teeth. Now, many places in Nepal, India, and other Eastern countries, you would find that brushing teeth at night is not very common. So, so we spend hours talking to people about the importance of brushing teeth. And then we also used to train school children about how to brush their teeth and talk about oral hygiene, and also practically show them. And we are grateful to the organization called DentAid. Many of you must have heard it. They have adopted one school near, which is in a remote area not far from where we are at. So we frequently visited them and provided them toothbrush and toothpaste with the support of DentAid. And also we went to the Himalaya region and trained children there and supplied them toothbrush and toothpaste. And not only students, we also trained teachers. Before COVID, we visited different schools, different villages, and talked to them about importance of brushing and the brushing technique. Now, when lockdown was introduced, of course, it was chaotic. We were not sure, we were not sure what is going to happen. The term lockdown itself, first of all, the term lockdown is not a new to us, because uh, we had, as some of you already know, that we had a lot of political instability in country, and so a lot of time there were strikes and curfews. So we were used to lockdown. However, we were not so used to sanitizer. And then when this lockdown was introduced, we were thinking, what is COVID-19? No one, we were worried that people, only surgeons or the doctors are, being more given attention. Why not to dental department? Because we work directly on, in the mouth. And then when this lockdown was introduced, we had lots of messages from our friends around Nepal, or also from other places in India, and from different parts of the world, talking, thinking, they were thinking of us like, hey, be careful. Now we took it very seriously, and so, but we did not know how to present ourselves in the department. So we were sort of panicking, although we tried not to expose it. I personally tried not to expose it that I was panicking, but within me I was panicking. And then we get the news from CNN, BBC. Is that a real news? Is that a fake news about COVID-19? Myths. And then, should we close down the services? Should we not close down the services? And so, the other questions were, when would this COVID-19 end? So we were obviously having so many difficulties uh, facing this. So the introduction, of course, to us was not easy. And so, by God's grace, we have a very good team here. We call this the team infection prevention team. Now, they prepared themselves to teach us, our staff, regarding how to face COVID-19, how to prepare ourselves. So, our sisters, the nurses, when I say sisters, that's the nurses. So they took real effort to talk to us and to train us. And then that helped us prepare ourselves, um, to face COVID-19. And so, I also must say that we all, as a staff, we had this psychological impact about, should we really work in the dental department? Should we not work in the dental department? And so we decided that for about 1 week we worked for half a day, but then we thought, okay, we must continue with proper mask and whatever the resources available. Now, as many different parts of the world, we also had difficulties in having access to the mask and to the PPE. You see, PPE is, although we knew this, I personally must say I really did not know the full form of PPE, to be very honest, because I never had to use that. And so, and then its availability, and should I be working without it? And because we had this good preparation from our staff, so I had that courage and also encouragement from other friends, that we can still go and work, to meet the need of people. Now, the infection prevention team, as I said earlier, they really help us prepare. Once we learn how to don and doff, and then how to put on mask, and how to, put on gloves, and how to take extra measures. I think that not only help the dental department staff, but also the other hospital staff to prepare ourselves to face COVID-19. And so, you know, during that time when, during the month of April, when this happened, the number of patients went down, and, and gradually hospitals around our town, many hospitals, in fact, they would not admit or receive patients without PCR reports. So, because, but our hospital was the one, even today, to this day, we don't ask patients for the PCR reports before procedure. And so that really leads to the risk of exposure for us. However, the suspicious patients, we send, or we require them to have a PCR test done. Now, also by this time, patients know that if they give correct information, they will not be seen in the hospital, which they have in their mind. So therefore, patients do not always give correct information about their travel history. So that was a challenging for the dental department and for the hospital as well. And so, you know, so the present situation, what happens, I just want to show it to you. After we have had training, now how we manage our patient for the dental department. Now, patient enters to the hospital. The moment they enter, they are being screened. I'll show you later pictures. So, they are being screened at the hospital gate by our dedicated staff. And if the patients are asymptomatic, they then go for registration. And then if they are symptomatic, then we have a area, we call it as a fever clinic, and then they are being sent to the fever clinic. And from registration area, now they register for, for dental ticket. And then from dental, when they come to dental, we ask the patients to remove their masks, wash their hands with soap, and then we again screen them and take a history. And once we find that they are symptomatic, then we send them to fever clinic. And if they are asymptomatic, and then we take them to our department to do the further procedure. And once the procedure is finished, and then patient go out of the hospital. Now, I'll show that to you step by step. So this is how their patients are being screened the moment they come in to the hospital. And then they go, sorry, the picture quality is not that good, but they queue up, and then they get their register done for the dental department. And then we ask patient to remove their mask and then wash their hands with soap and water. So we don't give them sanitizer, because we believe that soap and water is much effective than sanitizer. That's what we think. So step 4, we talk to patient, and then we ask them about their travel history, as I said earlier, and then if they have had contact with people with COVID-19. And as I said earlier, it's less likely that people give correct information because they are afraid that we don't see them. Actually, even though they have had contact with COVID-19, we have a provision. Even though they are symptomatic, we have a provision that we see them, with the full PPE, We go when we may not, we of course will not be able to do restoration, but for extractions and examination, we are prepared to do that. Even our patients are diagnosed with COVID-19. So as I said earlier, if patients are found asymptomatic, we take them to the chair, we do the needed procedure. Now, compared to before COVID, now we do not do, we try to avoid long contact with patients. What does that mean? That means we do not do many procedures. Like earlier, we used to do 5, 6 restorations per patient because our patient travels from long distance. Sometimes our patient comes from long distance. So now we only do maybe maximum of 2 to 3 cavities per person because we want to make sure that we minimize contact time with patients. Now, if we find, as I said earlier, if we find patients with symptoms, and then we send them to fever clinic, and then they will be tested there, or they will be admitted in the hospital, depending upon patient situation. And then if asymptomatic, then we give them a treatment. Now, how this has affected our community. Now, many people, they prefer not to come to dental department and hospital. So I'm sure as in many people, around the world, now people prefer to, stay at home and do all the other, take other precautions or remedies to to treat their teeth at home, and prefer not to come at the hospital. So how that has affected? As a result, the caries are not being taken, they're not being filled. And from the month of April 2020 till the October, we have had 12 patients with dental abscess, adults and other children. So we had to, admit them, and with the help of so when they are admitted, with the help of surgeon, we perform incisions and drainage, and then we extract teeth. So the reason for this is because they could not travel to our clinic on time. And many people in Nepal, unlike other developed country, we don't have private vehicles as many as other people would have. So the public vehicles are still restricted, not restricted as before, but people still hesitate to travel on public vehicles. So in conclusion, I would like to say, in all things, God works for the good of those who love him, who have been called according to his purpose. I believe there are so many other good things have been introduced in this world, in the lives of people, in the lives of believers because of COVID-19. I don't have much time to talk about what are the good things have come in our life. There are so many good things that have come. We have learned professionally, we have learned to protect ourselves, which I personally did not take that serious before COVID-19, but during COVID-19, now I'm learning that, and which is very helpful for me personally and for my team in the dental department as well. So I believe God has the reason to allow this COVID-19 virus to come into this world, and I believe he's teaching many of us to rely and to lean on him. So which is, I believe, which is great. And we continue to pray for those doctors and healthcare workers and scientists who are working on the vaccines and medicine. So thank you once again for listening to me and for joining me in this Zoom webinar. Thank you so much.
Thank you very much. We've been listening to Dr. Roshan Kharel, who is the Deputy Superintendent at United Mission Hospital in Nepal, speaking on dentistry in remote settings during COVID. And we're now going to move into a time of questions. We've got a lot of dentists and dental students who are listening today. And the first question comes from Hedwin Cadrianto. Hedwin is an Associate Executive Officer with ICMDA, and he's based in East Java. And his question is, what do you think regarding the use of negative pressure and modified ventilation in the dental room? Are you using this? And if not, why not?
Yeah, well, thank you so much for this answer, for the question, and for allowing me to answer this. I wish we had that kind of sophisticated room, but we have a normal room with good ventilation. So, we just, we don't take any extra precautions. It's just the same. The difference is these days, after like 3 hours, we have a break, or maybe 4 hours, we have a lunch break. So during lunch break, our housekeeping staff, they come and they clean the floor, they clean the wall with sodium hypochlorite. That's the only thing that we are doing it. And we clean the doors, but we don't have that, creating the negative pressure and, isolating the room and the disinfectant. The only disinfectant that we use is sodium hypochlorite.
And are you using disinfectant between patients? Do you disinfect the whole room between every patient with sodium hypochlorite?
Mm-hmm. We disinfect the chair, the dental chair, but not whole room. So wherever patient sits, we clean that area, we move that area with the sodium hypochlorite. That's the only thing that we are doing. Earlier, we only used to clean, with soap water, but now we use sodium hypochlorite as suggested by our team.
Now, you talked about certain procedures that you do and don't do at the moment, and you said, can you explain your rationale not for doing restorations, but for treating cavities, abscesses, and doing extractions? What criteria do you use to decide what you're going to offer and what you can't offer?
Yes, well, the restriction is not on the restoration. The restriction is on the scaling, which I had forgotten to mention that. Now, what we have restricted is number of procedures like restorations. For example, we try to minimize contact with patient for long term. For example, if I do 5 restoration on one patient, it takes long time. So therefore, to avoid long-term contact with patients, we only do like maybe maximum of 3 restoration or maybe 2 to 3 restorations. Now, because of aerosol that is created when we do scaling, and of course, during restoration also, aerosols is created, but we use face shield, we use double mask. So, so we do not have those facilities. If we can bring it in Nepal, but the thing is, this all cost will be added on to patient. So that, for majority of the patient, the cost won't be affordable. So, by God's grace, I don't have any scientific, proof to show that the way we are doing it is perfect. No, it is not perfect. And I don't think, and as much as I have read some articles, there are no procedures or the technique that gives 100% of assurance that I won't get virus. So we believe that just with the 2 masks and face shield and the cover that we put it on our dress, I think that is enough to protect ourselves from the virus.
Have any of your dentists or dental staff caught the virus during this period and had to have time off?
Mm-hmm. Well, thank you for asking this question. Yeah, there has been one dentist who is talking to you right now, has had affected by a virus. Now, the good thing is, I believe, and we in the team, we believe that it is not because of my presence in the dental department and the work in the dental department. It is because I was visiting and counseling one of my staff, not dental department staff, but another hospital staff. I frequently visited him. I counseled him. He had some health issues. And then later he was diagnosed with COVID-19. And it is more likely that I have got that from him. but not from the dental procedures. And none of my other staff have been affected or diagnosed with COVID-19 or have had any symptoms of COVID-19.
And did you have to take some time off during after that exposure? How badly were you affected by it? And how did the department cope in your absence? Did you have enough people to cover?
I have got another colleague. We are two dentists in Tanzan in my clinic. So my other colleague, she she of course she took off all the load in my absence. And so when this friend of mine who I was counseling was diagnosed, even though I did not have symptoms at that time, but my role in management and I have to go to visit different departments and attend different meetings, my medical superintendent and hospital director suggested that I better have a checkup, I better have had the test. And then, which I was thinking it will come negative because I had no symptoms at all. But later after I was tested and then I was tested positive. And from the day that I was tested positive, I started having mild symptoms. Like I had a, running nose, tears, and then, watery eyes, and then, I had body ache, but it was not so bad. I could cope up with it. And so it was not very bad. So I was home isolated, and thanks be to hospital management, as all our staff have a provision of having a leave with pay for 2 weeks. And so for which I'm grateful to hospital management. So I was given leave. So it was a time for me to rest.
Now, you talked about the screening procedure. I wonder if I could just ask you a couple of questions about that. So you divide people into two groups as to whether they're symptomatic or asymptomatic. And then you said that those who are symptomatic, you test before they have treatment. How do you test them? And do you wait for the results before initiating treatment? We're using PCR screens, or what?
Yes, our hospital does not have a testing machine like RT-PCR, but in Tanzan, the government hospital has the testing equipment there, PCR. And so when patient comes, when we find that they have symptoms, so we send them to our fever clinic where our GPs and other doctors will be attending them. And if they find, based upon their severity, if they are, if they have severe symptoms, then they will be asked to be admitted. And when they are admitted, and then our hospital, other hospital staff will take a swab and then send it for the test to the lab in the town, where the government is running this lab to for PCR. Now, if the patient has some mild symptoms or maybe without symptoms, but has a travel history and has a history of contact with the patients with COVID-19, then we recommend those patients possible symptomatic, possible that they will be COVID-19, but they are not without, they're not with symptoms. So we request them to be home isolated, and then they are sent home. So that's how we differentiate. And then after they will come back after a week or 10 days, and then if things are all normal and without test, we will do procedure.
Okay, so I understand from that you're really only doing procedures on people who are asymptomatic for
absolutely
for COVID, but everyone else you send home to isolate. If there's a suspicion or a positive test, you don't carry out any procedures on them.
Yes.
Okay, so I was going to ask you if how you handled actually in the dental theatre patients with or without symptoms, whether you handle them differently, but you've answered that question already, because I guess the question would then be, what if it is a dental emergency, if the person has an abscess that needs draining or severe pain or something, and they need immediate treatment, and yet they are also symptomatic or suspicious of COVID. what do you do then? And
Mhm.
and do you treat them in any different way in the dental theatre than you would for an asymptomatic patient?
Yes. For patients with symptoms, we have a plan. Like, the hospital has set up the surgical, the operating room for surgical procedures for other COVID-19 patients. So, the plan is that we will not be doing any other restoration or aerosol procedures that creates aerosol. So we won't be doing scaling or restoration. But for incision drainage, extractions, with PPE on, in that assigned or designated operating room, we will be doing procedure for patient with COVID-19 for those
Okay.
emergencies.
Yeah.
Mm-hmm.
Another question here from Shirley Lau. Are patients given antimicrobial mouth rinses prior to treatment?
Sorry, read that question again. I didn't hear you.
Are patients given antimicrobial mouthwashes, mouth rinses prior to having treatment?
Yes, we have antimicrobial mouthwashes available here, but mostly, unless they have severe periodontal conditions, we prefer to advise them to rinse their mouth with salt water, salt and warm water. So that to avoid use of chemical and antimicrobial, we suggest our patient mostly to rinse their mouth with warm water and salt. But yes, we do have antimicrobial, mouthwash, which we only give it to patient with severe periodontal those who are in periodontal, those who have periodontal conditions. Yes, we do use it.
Now, you spoke to us quite a bit, Dr. Kharel, about the educational programs that you were doing in schools and prisons and for teachers in the community. And Karen Hendrickson is asking here, she says, thank you for your interesting presentation. How do you see your prevention programs moving forward now in COVID times? Are they still happening? Or if not, and if so, how have you modified them during COVID?
Well, thank you so much for this question. It has been in our heart because we believe, one of the values of our hospital is to work on to train people and work on prevention of disease. So now, unfortunately, we have not been able to travel even though we want. So in prison, when the lockdown was introduced, the jailer from the local prison had sent us the mail saying, inviting us to come to the prison before, the starts the community spread in Tanzan. Now, as we were preparing, the next day, again, the jailer calls, look, the home ministry from Kathmandu has now not allowed anyone to come into the prison. So unfortunately, we couldn't visit any of the prisons from the month of April. And as for the prevention program, we have not been able to do it. Now, I don't see that in near future we will be able to visit schools because schools have just started opening, and the school timing has been cut short for like half, maybe like three. Now the school runs only for like 2.5 hours or 3 hours. So I do not see that it will be possible for us to visit. And I think it is good because then so that we do not pass on virus if we have to the children, or we don't get it from other people as well. So I guess we are we don't have a immediate plan to visit to different places, although we want to.
What's the situation now with COVID in Nepal? How many cases are you seeing? Are the numbers getting worse or better? And
Yes.
How are you seeing a lot of cases in the hospital generally outside the dentistry department?
Mm-hmm. Yes. Right now, I don't remember in my head, but I know that the number of cases are increasing significantly. As per the hospital, I think this information will help you understand how the situation are getting worse in Tanzania. Is earlier, like 5 months ago, we only used to have one or two patients asymptomatic, suspected ones, one or two patients suspected ones, and then one died. It was 5 months ago. But now, all our medical ward that we had, it is now been converted to COVID ward because we are getting many patients, and we, as per government regulations, all hospitals must have, I think it's 50% of their bed numbers should be, allocated for COVID-19 patient. But we haven't, because of the infrastructure, it's very challenging to allocate 50% of our bed for COVID-19 patients. But there, one of the wards, which is medical ward, has been allocated for um, the patients with COVID-19. And so, with this, and also that we thus far, if I remember, they're like we have had about 27, 28 hospital staff who have been infected, and I think 90% of us have been back to work. And so currently we have about 20 staff, hospital staff, who have been diagnosed with COVID-19. So, there has been community transmission in Tanzan as well. So things are getting worse. But I can see that all of us, now we are getting, we're not panicking as we used to during the month of April.
A question now from Doug Lindberg, who's asking, do you put a special emphasis on care for pregnant women at Tanzan in light of the impact that dental health has on pregnancy outcomes? Mm-hmm. And how has this been impacted by the COVID pandemic?
Mm-hmm. Yeah, thank you for this question. I must say that, we, any patient coming to us, whether, pregnant women or others, we do not have special, preferences to group of patients. If pregnant women come with dental problems, we see them as, as to other patients. So we do not have special preferences or, policies to just to take care of pregnant women separately. If they develop any symptoms or if they have problem, we treat them as if we are treating other patients. So the only, the different approach to them would be, other patient would come to dental department, but if the pregnant women, if they're not able to move or if they're admitted in the hospital, we go and visit them in the ward. So yeah, we don't ignore them, but we treat them as we treat other patients. I don't know, have I answered that question?
Okay, thanks. Yeah, that's very helpful. Any special precautions for sterilization of instruments during this scenario? Are you handling your dental instruments any differently than you would normally?
No, exactly. We are handling our instrument exactly the way we used to do it before COVID. So there is no any special sterilization process that we're doing it. I can say that earlier, we did not give much time in washing our dental chairs or even washing our elbows, washing up to elbows. Now we are, washing ourselves and the dental chairs and our walls. But the method of sterilization is same. We haven't changed anything. Same as before COVID-19.
Thank you. Please keep your questions coming in. Use the Q&A box at the bottom, and then after typing them, we will ask them of Dr. Kharel, and then you can upvote other people's questions as well, which makes it more likely for them to be asked. Now, Dr. Kharel, you mentioned that there were 12 dental abscesses that you've seen during this period. Is that a higher number than you would normally see in a similar period?
Yes, that's significantly higher number. I used to see this patient, this is my 20th year running, working in Tanzan hospital. I would say 18 years ago, the frequency of dental abscess used to be same as now, because 20 years ago the road access was very difficult for patient to come and visit our hospital. Now similar thing is happening now. So I would say compared to last year or 5 years ago, the rate of dental abscess has significantly grown, and the reason is because of the road transportation. But rich people are able to come by their own vehicle, or they pay extra to ambulance and they can travel. But it's mostly the middle class ones, middle class people, or the people with low income. They're not able to come, so they are the ones they end up with dental abscess.
So you're seeing a lot fewer dental patients than you would normally see. Do you think that's entirely due to disruption in public transport, or do you think that patients are staying away because they're perhaps afraid of catching COVID, or afraid for other reasons? What's your feeling on that?
The local people from within Tanzan is because of the fear, and because of their fear to come to the hospital and possibility of catching the virus. And also to some extent, I'm just guessing this because I haven't done any so-called research. But my guess is that people from outside of Tanzan, because of difficult to get here, they could not travel here, and then so that's why the cavities went on to the dental abscess to become dental abscess. So
now presumably there must be quite a lot of dental disease building up in the community if people are coming in just because they have dental abscesses or emergencies, and you're seeing a higher number of those because of delays in treatment. Do you think there is a big buildup of untreated tooth decay, people needing fillings or extractions in the community at the moment? And how do you have any measure of that? And how do you anticipate dealing with that backlog once the COVID pandemic begins to settle? Seems like he's disappeared. I guess this is one of the challenges of doing dentistry in remote settings also, is the difficulty with internet connections as well. But we're hearing a very, very similar story from many remote setting environments all over the world, that there's been huge disruptions in public transport, and that those have led to a huge decrease of patients coming to hospital for routine treatment or for emergency treatment. And so we know there are a lot of people in the community who are not getting adequate treatment, and that there will be a buildup of cases. We talk about the 4 different COVID curves. The first one is the number of people with COVID who are presenting, and then the second one is people with urgent conditions who are not able to get treatment for those urgent conditions, cancers, heart disease, infections, and so on. And then there's a third curve of people with chronic conditions like diabetes or high blood pressure who are not able to get treatment. Also the impact, of course, on immunizations. And then we see the mental health curve as well. Dr. Kharel, do we have you back again?
Yes, I'm sorry, I got disconnected.
It's no trouble at all, and we've been waiting for you to return. So should I just ask you that question again?
Sure, please do that.
So I was asking, given the big delays in people coming for treatment and the disruption to public transport that's happening, and the fact that you're seeing more serious complications like dental abscesses, there must be quite a buildup of dental disease in the community at the moment. And what do you anticipate is going to happen once COVID settles, and how are you preparing for that increase of treatment that might be coming your way after the pandemic is over?
Well, thank you so much, Peter. This is actually a very challenging question, which I'm challenged right now. I'll be started thinking about it from tomorrow, or well, from now on, because never thought of that. I know that it has built up. There are many, I can see that after things get normalized, I can imagine that we will, the amount of, the number of patients that they will be coming here, it would, it will be very difficult. And I think this is the area of study that I think now it has now encouraged me, to work on that. And I think I'll put some effort to see, and then we'll be working on how I can manage that. And I think I have to work with along with my colleagues, not only from my hospital, also from other hospitals around us. I think we have to think about it collectively. I haven't put my thought on that, but it's a very good and challenging question.
Another anonymous question, Dr. Kharel here. In my hospital where I work, we use waterproof gowns and spray rectified spirit after each patient, and sometimes at the end of the day. Is this enough for disinfecting, or do you suggest any other methods?
I think that's excellent. We do not have, I cannot afford to have waterproof gown for every patient. So I think that's excellent. I don't use waterproof gown, not because that hospital cannot afford it. I think hospital can afford it, but if you see the patients that they come to me, they cannot afford to pay for that. And so, I think that waterproof gowns are excellent. The only challenging thing is, I think you have to change that for every patient. Otherwise, I'm afraid that if we do not change the gown, then we can transfer virus from one patient to another. But yeah, having waterproof gown is the best. If your patient can afford it, yeah, go ahead and use that. I would love to use it, but unfortunately, not all my patients can afford that.
Thank you. We've got another question here from Karen Henriksen. Has your COVID experience influenced your plans for prevention down the road when travel is possible? And could you comment on the use of mobile clinics and also the use of fluoride treatments and sealants in mobile units? So
Yes.
I guess there's two questions there. How is your experience going to change the way you do prevention? And also, what sort of treatments or preventive methods do you think you'll be able to put out into the community as opposed to doing them in the hospital?
So prevention is prevention for dental decay. That's what I understand, right?
Yeah, yeah.
Okay. One of the answers to Dr. Peter's question is right here is after COVID-19, post-COVID, I think this is one of the areas that I, along with my team, need to work on prevention on, the dental cavity and applying of silver diamond fluoride and, use of fluoridated toothpaste and the use of topical fluorides on school children. I think this is something that answers one of the questions that Dr. Peter had asked me for future plan. And currently, what we are doing in my clinic here in hospital is, along with my colleagues in the department, we train every mothers of parents who come with their children. We spend time teaching them how to brush or supervise brushing their children's teeth. And so we take extra time in explaining them the importance of brushing and rinsing their mouth. Now you see, flossing is not as common in Nepal as it would be in the Western country. Flossing is still, it is not a new thing, but people, it's not common in Nepal to floss. And so we spend most of our time training mothers and fathers and children about the importance of brushing and technique of brushing. But after post-COVID-19, I think we will definitely, it would be very helpful to conduct a mobile clinic in different schools and in different villages. I think that would be excellent. That's the strategy I think we have to take on after COVID-19.
Thank you. A question from Christopher here. Considering how we're limiting contact time with each patient, is it still viable to do root canal treatments for necrotic teeth, or are you preferring just to do extractions in those circumstances?
Yes. For the necrotic tooth, yes, we do perform root canals. As I said earlier, before COVID-19, I would do root canal and I will do a couple of fillings for the patients. But now, if I'm doing root canal, the first procedure, then I would not do restoration, because root canal itself takes a long time, a long contact. So when I'm doing the opening of the canal, I would not do restoration. But the next visit, when I'm doing irrigation of the canal, when I'm following the visit, then I would do maybe one or two cavities along with irrigating the canals.
Thank you. Another question here from Hedwin in Indonesia, who is a dentist himself, just exploring international comparisons. And he says, how many patients come to you in a day on average? And perhaps you'd like that to answer that before COVID and after COVID. And how long do you work as a dentist in a day? And how many personnel work in dentistry in Tanzan hospital in a given day?
Yeah, we are 6 people working in the dental department. We have 2 dentists. That's me, and I have another colleague who works with me, and we have 1 dental hygienist, and we have 3 dental assistant. Now, before COVID, we used to see like 25, 28 patients per day, but now we are seeing 15, 17 maximum per day.
Okay.
Because the number of patients, as I said earlier, they have gone down. And also, even if we have like 20 patients, we would not do more procedure, because cleaning, sterilizing our instruments, and also cleaning our chairs and preparing ourselves takes time. So we're not able to, cope up with patient more than maybe 15 patients a day. And how much do we charge for dental extraction? We have different charges for dental extractions. Now, 1 USD is 100 how much? Maybe 10 Nepali rupees. Okay, so $1 is 110 Nepali rupees. For simple extraction, we charge 350 Nepali rupees. So that's approximately
about $3.
$3 for simple extractions. But if it is surgical, if I have to do surgical for impaction, it would be like, I would say $12. So that's a variation.
Okay.
Mm-hmm.
Thank you very much. I think we've probably run out of time now, but there's just some other comments thanking you for your interesting presentation. Free Blessing from Zimbabwe sends regards, because he's worked with DentAid as well. Nice. In two missions. Great to hear that all around the world DentAid is working in both Asia and Africa. And it's been wonderful today to host this session for our dentist members, and we've had up to 60 people on the call from many different countries, and many of them from poor resource situations where you're facing the same kind of challenges. And we're very grateful to you to share of your experience and to learn from that today. So it just remains for me again to thank you so much, Dr. Roshan Kharel from Tanzan Mission Hospital in Nepal, for speaking to us on dentistry in remote settings, and to thank all of you for coming along today and being part of this experience. May the Lord bless you, and we look forward to seeing you again shortly on ICMDA webinars. Thank you.
Yes, thank you so much once again for thinking of me and for allowing me to give this presentation. And thanks to all the participants for your encouragement and for your time to listen to me. Thank you.